Thank you. Today I just wanted to cover a few things that I think are a little underappreciated, comorbidities that are underappreciated or maybe misunderstood a little bit in ME/CFS. So the Bateman Horne Center does not endorse or recommend any specific products, services, or companies mentioned in the presentation. This is all for informational purposes, and we have no financial relationship nor benefit from the inclusion of anything covered today. We are a nonprofit organization that is dedicated to clinical care, research, and providing educational resources for those with ME/CFS, long COVID, and related comorbidities. So I wanted to go through today by looking at some key questions that I think help guide chronic management for complex patient cases that go beyond sort of our basic post-exertional malaise, orthostatic intolerance, et cetera. So one of the first questions I think that we need to think about a little bit more is, do patients have hypermobile Ehlers-Danlos syndrome, or do they have a hypermobile spectrum disorder? So self-reported data in a cross-sectional study of those with ME/CFS suggests that 15% have joint hypermobility, and 28% of those with long COVID ME/CFS report generalized joint hypermobility. In another self-reporting prospective observational study, individuals with generalized joint hypermobility were approximately 30% more likely to experience chronic symptoms after recovery from acute infection by SARS-CoV-2, with many of these patients going on to meet criteria for ME/CFS. And I think these are actually probably underestimates for how much joint hypermobility syndrome we actually see. How do we make this flow into the Ehlers-Danlos Society right now? We start by using the Bateman score, which is really how most clinicians would assess this in a clinic. You're looking for hypermobility in the fingers, specifically at the pinky fingers, at the thumbs, at the knees, at the elbows. You get a score of 1 for hypermobility at each of these bilateral places, and then for being able to bend over and touch one's palms to the floor easily. If you score 5 out of 9 as an adult, that's considered positive. 6 out of 9 for children, since they are more flexible, and as you get older you do get a little more stiff, so you only need a score of 4 out of 9 to reach the Bateman score at that point. Formal diagnosis, however, requires more than just the Bateman criteria. You also need to meet these pretty extensive criteria here, criterion 2 and criterion 3. But I would say that it's important to remember that there are lots of other obvious hypermobile findings that are not included in this Bateman score, and that the EDS Society is actually looking at potentially changing these diagnostic criteria soon. So as we come to better understand the genetic, epigenetic influences and molecular pathology that goes into hypermobile spectrum disorders. And this is just a few examples of other types of hypermobility people can have that don't really fit into that Bateman score. I think it's important to remember that patients with HEDS, one of the reasons, there's a lot of reasons we want to recognize this, but one of them is that there's a lot of close associations between HEDS and many of the other comorbid conditions we find in ME/CFS, including POTS, mast cell activation syndrome, small fiber polyneuropathy, gastrointestinal dysmotility, central nervous system complications, and a lot of vascular pathologies as well. I think it's important to consider whether or not a patient has mast cell activation syndrome. And while I don't think this is maybe new to a lot of people, I think that there are some different ways of looking at this. So the exact prevalence of mast cell activation in ME/CFS is still being investigated, and much like ME/CFS, patients with MCAS often can remain symptomatic for decades before they're appropriately diagnosed and treated. One study comparing 80 MCAS patients with 136 long COVID ME/CFS patients found a nearly identical symptom presentation and severity analysis between the two groups, and you can see that here on these spiderweb plots. Nearly 1 in 3 patients with MCAS has a comorbid diagnosis of HEDS, and in one study, 66% of patients with POTS and DES also met criteria for mast cell activation syndrome. So these things all cluster together. What is mast cell activation syndrome, though? At its core, it is characterized by the aberrant or abnormal release of mast cell inflammatory mediators in tissues, and that is sometimes independent of what we traditionally think of as IgE-mediated allergic triggers. This can then lead to chronic and multi-systemic symptoms. In addition to traditional allergic triggers, mast cells can be stimulated to degranulate by a wide variety of other cellular triggers, and that can be anything from bacteria, drugs, foods, fungi, heavy metals, organophosphates, viruses, mold, cellular danger signals, UV light from the sun, vibration, even stress hormones like corticotrophin-releasing hormone, and many other molecules. So mast cells are not just leukotrienes, histamine, and tryptase. I think a lot of clinicians think about mast cell activation from an allergic perspective, but there's a lot more to this. And in fact, when activated, mast cells can release over hundreds of different mediators. Some of these mediators are immediately released when they're activated, others are released several minutes later, and then others even within hours of activation. It's important to remember that mast cells are found in different tissues, and in those different tissues, they behave differently, including different things that activate them, different membrane receptor expression, and different cytokine and chemokine release. Activated mast cells, no matter where they are initially stimulated, may also send distress signals via neurological or immune pathways throughout the body, triggering mast cell responses in other tissues or distal tissues as well. So, for example, eating something or taking a medication that causes a mast cell reaction in the gut can lead to signal transduction, leads to mast cell activation symptoms in the brain, in the skin for rashes and itching, etc. Mast cells are found in the brain, particularly in the hypothalamus, thalamus, third ventricle, pituitary gland, and the pineal glands. And in MCAS, mast cells are often notably activated and affected by emotional stress via the effects of corticotrophin-releasing hormone. Mast cells also appear to regulate the permeability of the blood-brain barrier, something that's been occasionally implicated in some of the pathophysiology of ME/CFS. Mast cell mediators, such as histamine and tryptase that are released from mast cells, can also activate microglial cells in the brain. And these microglial cells actually act as a part of the innate immune system and release their own pro-inflammatory mediators. Microglial cell activation and neuroinflammation are implicated. Microglial cell activation is implicated in triggering neuroinflammation in multiple brain disorders and possibly that which contributes to the brain fog and cognitive dysfunction in ME/CFS and long COVID. So that may be somewhat mediated by mast cell activation. There are lots of different potential triggers for mast cells. They're extensive. They can be anything in the environment from heat and cold, stress, exercise, fatigue, food, beverages, drugs, odors, venoms, getting infected with viruses, bacteria, fungi, mold, mechanical irritation, such as on the skin. You see a figure here of dermatographism, and even sun or sunlight. Mast cell activation syndrome symptoms are also extensive, and this is a list of a lot of sort of allergic type symptoms, food allergies, asthma, atopy, etc. I think a lot of people are familiar with these, and a lot of clinicians are particularly familiar with these, but I wanted to focus a little bit more on how mast cell may interact with comorbid conditions, including things like POTS, hypermobility, fibromyalgia, migraines, chemical sensitivities, neuropsychiatric conditions, irritable bowel syndrome, endometriosis, interstitial cystitis, and even neuroanatomical issues like craniocervical instability and atlantoaxial instability. So mast cells play a significant role, we're finding, in tissue remodeling, wound healing, and growth. And when we look at patellar tendinopathy, mast cells have been found to accumulate within the knee and may be playing a role in this type of inflammation of the tendon when it was previously considered an overuse injury. Mast cells may play a major role in hypermobility. Irregular, recurrent, or chronic release of mast cell-mediated cytokines has been linked to hypermobility and other heritable connective tissue diseases. Mast cells in the connective tissue cause microenvironmental changes to the extracellular matrix, including IgE-mediated autoreactivity in these tissues. Mast cell inflammatory changes have been implicated in contributing to laxity of blood vessels and pooling of blood within the extremities, which is a common finding in POTS and dysautonomia. There was an interesting study in families that have heritable mutations in genes that encode for elevated tryptase levels, which is one of the proteases that's released from activated mast cells. And 28% of these patients were found to actually have joint hypermobility, which is nearly double that of the general population. So some are even postulating that mast cell activation syndrome and HEDS may not even be distinct clinical entities, and that they may exist together or be part of the same clinical entity, but a lot more research is needed to sort of confirm that. Irritable bowel syndrome is found at a much higher rate in those with mast cell activation syndrome. There was an odds ratio of 16.3 between those with IBS and those with mast cell activation syndrome. interstitial cystitis, which is an inflammation of the bladder that mimics things like a urinary tract infection, but for which no bacterial cause can be found, has been implicated to at least in part be mediated by mast cell activation syndrome. And they've seen increased numbers of mast cells and degranulation activity from mast cells in many with interstitial cystitis, especially in the ME/CFS, POTS, and HEDS communities. And I can say from personal experience that treating mast cell effectively often reduces these symptoms. Similarly, we've found higher concentrations of mast cells and greater mast cell activation and degranulation, as well as higher serum estrogen concentrations in the endometrial tissue of patients with ovarian endometriomas compared to controls. Increased mast cell numbers and degranulation and increased tissue estrogen measurements were directly correlated to the severity of endometriosis-associated dysmenorrhea as well. Furthermore, there's growing evidence for increased mast cell accumulation and activation in female genital tissue, causing pain known as vulvodynia, and this may be secondary to fungal infections such as candida or chemical exposures such as those found in detergents. Treatment for MCAS with reducing therapies such as imatinib or ketotifen have actually shown reductions in tactile sensitivity in animal models. And I can say in humans, there have been several strategies now employed to try to reduce mast cell activation that have improved vulvodynia. Mast cells are highly implicated in the pathology of migraines. Mast cells are located in the perivascular distributions or around the blood vessels in close association with the dura mater of the central nervous system. These mast cells are then activated following stimulation from the trigeminal nerve or other nerve regions, often via something called calcitonin gene-related peptide. Serum histamine concentrations then increase with this mast cell activation during a migraine attack, which leads to further blood vessel dilation in the meningeal blood vessels. And then other mast cell inflammatory mediators activate meningeal nociceptors or pain receptors, both triggering sensory nerve fibers to transmit pain signals and further propagating more release of calcitonin gene-related peptide and other neuropeptides that propagate migraines. And this is just to point out that many food-induced migraines are thought to be mast cell mediated. Neuropsychiatric disorders have even been implicated as having roots in mast cell activation syndrome. And there was an interesting case series of 8 patients with significant neuropsychiatric disorders that were refractory to standard medical therapies. 5 of these patients had depression, 5 generalized anxiety disorder, 4 panic disorder, and then they also had diagnoses of OCD, bipolar, compulsive disorder, ADHD. All 8 of these patients were subsequently diagnosed with mast cell activation syndrome. And then 6 of them had POTS, 4 of them had HEDS, and they experienced significant improvement in both neuropsychiatric and multisystemic symptoms after mast cell was identified and treated. So one of the quotes from that paper is that my primary care physician finally referred me to a neurologist for POTS, and my life changed at that appointment when he diagnosed me with MCAS. He assured me my symptoms were not in my head, but in my brain. He started me on the MCAS protocol, and although some symptoms were better, the depression was not. He referred me to a specialist who tried other medications and eventually added chemotherapy drug called hydroxyurea. Shortly after starting this drug, my suicidal thoughts finally stopped, and I have not had any desire to die since. I am truly happy for the first time in my life. So after you identify mast cell and its implication in all of these different comorbid conditions, what are our actual goals of trying to treat mast cell? I think it's pretty obvious that we want to reduce symptoms of allergy, atopy, asthma, and anaphylaxis. We've been doing that in clinical medicine for a long time, but there's a lot more to it than that. I often find those symptoms to be the canary in the coal mine, right? If you're highly unable to function and have severe symptoms of ME/CFS, you're not so worried about your runny nose or your stuffy nose after eating. But what that's telling us is that, in fact, mast cells are likely active in these other tissues and contributing to the pathologies just discussed, even if we can't measure those in real time. So that runny nose or that dyspepsia after eating is sort of a clue that that's going on at a deeper level. So not only do we want to reduce these allergy and asthma symptoms, but we want to reduce triggers for neuroinflammation and propagation of migraine headaches. We want to reduce triggers for exaggerated dysautonomia behaviors that mediate things like orthostatic intolerance, GI dysmotility, and sympathetic overdrive responses. We want to reduce inflammation at connective tissue interfaces that may lead to increased blood-brain barrier permeability, increased vascular permeability and endovascular inflammation, or even increased intestinal permeability with GI translocation of gut bacteria. We also want to reduce the breakdown of connective tissues that support joints, muscles, and neurovascular structures, and that may even contribute to neuroanatomical complications like craniocervical instability or tethered cord. And lastly, there's some thought that we may be reducing new or perpetuated innate immune dysregulation that actually contributes to ME/CFS pathology or the continuity of that pathology when we reduce mast cell activation syndrome. So I often tell my patients treating mast cell is like flour for a cake. It is not sufficient for reducing all symptoms or improving mast cell or ME/CFS symptoms, but I do think it's necessary. You're not going to bake a cake unless you have good mast cell control. And it's my personal philosophy when treating mast cell activation that antihistamines and leukotriene antagonists may not be the best primary management tools because the things that are released from mast cells go way beyond just histamine and leukotrienes. So I personally prefer mast cell stabilizers or other mechanisms of mast cell depletion due to the opportunity for these therapies to inhibit mast cell behavior upstream of activation and to inhibit subsequent broad inflammatory response throughout tissues propagated by neurological and immune triggers. And I would say also that most mast cell therapy is well tolerated, safe for having a mast cell reaction to the therapies themselves, and it's generally safe without significant risk for adverse drug effects. So treating this aggressively really should be something we should be looking into, I think, more than we do in clinical medicine. One other point is that if you find it difficult as a clinician to control one aspect of your illness, such as orthostatic intolerance or sympathetic overdrive, sometimes looking at mast cell and treating mast cell better will allow you to better treat these other comorbid conditions. That it's actually mast cell that may be driving exacerbation of other comorbid conditions. Another clinical question to move on to: does this patient have significant non-visceral pain? And I wanted to point out in particular that we think small fiber polyneuropathy may play a major role in pain that patients experience. So small fiber nerves are small unmyelinated sensory afferent C fibers and thinly myelinated alpha delta fibers, as well as postganglionic sympathetic autonomic axons. These nerves are small diameter fibers that innervate most organs and tissues. And in addition to nociceptive or sensory signaling, they also have a lot of autonomic functions, including heart rate, blood pressure, sweat response, and GI function. So when thinking about specifically the pain response here, there was a study in 79 HEDAS patients who had amnestic or pain complaints. And when performing a test for small fiber polyneuropathy called a quantitative sensory test, 70% of those patients met criteria for small fiber polyneuropathy. Looking at the same group of patients, 78% of the patients were found to have or to meet criteria for small fiber polyneuropathy via a skin biopsy and an intraepidermal nerve fiber density test, which is the gold standard for diagnosis of small fiber polyneuropathy. So if you think about these patients as having a definite diagnosis of small fiber polyneuropathy, meeting both the qualitative and intraepidermal nerve fiber density testing, we found that 58% of patients with HEDS actually meet the criteria, with amnestic complaints, meet the criteria for small fiber polyneuropathy, and an additional 33% of patients met at least one of these two diagnostic criteria, meaning that patients with HEDS, only 9% of them did not meet criteria for small fiber polyneuropathy. And this is a heat map here of HEDS patients and a diagnosis of definite small fiber polyneuropathy, and they overlap very significantly. So for management of pain and central sensitization in small fiber polyneuropathy, we have a lot of tools, but I wanted to point out that while there's a lot of drugs that mitigate symptoms specifically, that mask symptoms, I think it's really important that we manage orthostatic intolerance by improving perfusion to muscles, nerves, that we improve sleep, which helps reduce central sensitization, that we treat mast cell activation syndrome as the tissue inflammation seems to really exacerbate symptoms of small fiber polyneuropathy, and that we avoid PEM. These are all major role players in driving symptoms of pain. And in fact, I often reach for treating these other conditions first, rather than reaching for these drugs to try to mitigate pain in patients with ME/CFS. It's also important to note that there's other sources of pain in those with hypermobility and ME/CFS, and particularly a lot of musculoskeletal complaints. So we have joint laxity and instability that alter joint loading and force distribution. We can have increased tendon laxity that can lead to difficulty with muscles transmitting power. and muscles appear to need to exert greater force to actually initiate joint movements and maintain joint stability. So this can allow for repeated soft tissue injury from joint instability. And then you get secondary local tissue inflammation and repair, which can alter pain signals and lead to lasting neuroplastic pain responses. So it's not only the musculoskeletal pain, but a change in your sensitization to pain as a result of these musculoskeletal triggers. You may have reduced proprioceptive acuity, which also increases the risk for musculoskeletal injury when you have HEDS. And so there's all kinds of different injuries and anatomical complications that we see in patients with hypermobility syndromes, including joint hyperextensions and subluxations, tendon and ligamentous stretching and tears. We see a lot of spinal issues, especially disc herniations. And I would point out that after fusion surgeries for disc herniations, tissues just proximal or next to a fusion now absorb more load and then frequently become injured after the initial surgical repair. It's something we need to think about. We see a lot of SI joint, which is the sacroiliac joint, hip and pelvis malpositioning, and a lot of hypertrophic and dystonic musculature, which with some muscles overactivated and others chronically underactivated, leading to altered biomechanics and kinesiology. There's a lot of physical therapy protocols that are designed to address the entire biomechanical chain and its kinesiology. And these are more likely to be helpful than addressing just shoulder pain or knee pain. So the Ehlers-Danlos Society recommends the Muldowney physical therapy protocol, although there's a lot of other good techniques as well that look at this. A lot of patients will present with gastrointestinal complications. And while we know that there are complications from mast cell activation, I also wanted to point out that some of the gastrointestinal complications we see can be mediated by small fiber polyneuropathy. And the gut is indeed densely innervated by small fiber nerves as well. And loss of these fibers leads to all kinds of digestive symptoms, including dysmotility, acid reflux, weight loss, lack of appetite, diarrhea, constipation, and a lot of things that we refer to as irritable bowel syndrome, and sometimes dismiss in patients otherwise. In one study, 49% of 129 patients evaluated at a tertiary neurogastroenterology clinic for delayed gastric emptying were actually found to meet criteria for joint hypermobility syndrome. So again, these things cluster. And then in another study of EDS patients at the Mayo Clinic, they noted abnormal gastric emptying in 22% of those patients. What was interesting is that that was pretty evenly divided between delayed gastric emptying and accelerated gastric emptying. And so what I want to point out here is that it's important to remember that unlike a diabetic gastroparesis, gastrointestinal dysmotility is not a fixed pathology, and it can be very intermittent in its presentation. So for diabetic gastroparesis, we actually have damage and malfunction of the nerves that control peristalsis of the gut. On the other hand, in GI dysmotility, this is a misbehavior of the nerves that control the gut peristalsis. And this misbehavior can be over-accelerated gastric emptying, delayed gastric emptying, or normal behavior. And it changes from moment to moment and time to time. And things that affect or drive dysautonomia symptoms will also drive this dysmotility. Symptoms of dysmotility include getting full quickly, called early satiety, bloating, belching, loss of appetite, upper gastrointestinal discomfort, and even in more severe cases, nausea and vomiting. And then we sometimes will see a secondary complication called small intestinal bacterial overgrowth as well. What do we do for this? Well, I think there's a lot of different ways to treat this from a clinical perspective, but what I really want to focus on is that traditional gastroenterology-based treatments may help reduce symptom burden, but in those that have more severe dysautonomia driving symptoms will not see sufficient symptom improvement until you actually treat what's driving the dysautonomia itself. So I've seen patients get gastric pacers and have pyloric sphincters and Botox at the lower portion of the stomach to open it up, and yet they still have dysmotility symptoms until we find the root cause of their dysautonomia. Sometimes that's upstream in the brainstem, or there's other causes, but until you treat that dysautonomia, you may not see full improvement of this dysmotility. Other things that lead to abdominal complaints, median arcuate ligament syndrome, or celiac artery compression syndrome, as it's called, which is defined by recurrent abdominal pain related to compression of the celiac artery or the celiac nerve plexus by the median arcuate ligament in this location here in the abdomen. Symptoms could be mediated by ischemia or lack of oxygen, by nerve compression, or by secondary inflammation, even mast cell activation, or by other neuropathic mechanisms. And it's characterized by a triad of postprandial abdominal pain, so that's after eating, weight loss, and a fear of eating, and then what we call an abdominal bruit, which is sort of an increased sound when you auscultate with a stethoscope on the abdomen. It is more common in females and will often present in the 4th decade of life. There are venous compression syndromes as well, like May-Turner syndrome, which is defined by extrinsic venous compression by the arterial system against bony structures in the iliocaval venous territory, which is most commonly that of the left common iliac vein compressed by the right common iliac artery. Partial obstruction can be asymptomatic, but progression can lead to formation of a deep venous thrombosis or a venous clot. And it's estimated that 2 to 5% of patients with EDS will actually have this. And it's more common in females and presents in the 2nd to 3rd decade of life. Symptoms include extremity pain, particularly left lower extremity pain and swelling, venous claudication, or signs of venous insufficiency in those lower extremities. There's another venous compression syndrome that's well defined called Nutcracker syndrome that refers to compression of the left renal vein between the aorta and the proximal superior mesenteric artery. And symptoms can include blood in the urine, orthostatic protein in the urine, or even left flank pain. And I think it's important to remember that these venous congestion syndromes vary depending on what position someone is in. So whether you're upright or supine, lying on your side, how much volume you have in your blood vessels, whether you've been loading on fluid and salt for orthostatic intolerance or dehydrated, even things like altitude and barometric pressure can alter the presentation of these symptoms. What about neuroanatomical complications that we see? Well, I think a lot of people are familiar with the idea of craniocervical instability and atlantoaxial instability, and it's growing a little more prominence in the field of ME/CFS. This is a manifestation of incompetence or hyperlaxity of ligamentous and bony elements supporting the cervical spine and the craniocervical junction, which is C0 to C1 or C1 to C2, that leads to increased motion at these sites. While it was traditionally thought to arise from neck trauma, abnormalities in expression, structure, function of the fibrillar collagen or connective tissue can lead to this ligamentous incompetence or hyperlaxity, leading to the increased mobility. And it's postulated that collagen or ligamentous incompetence may also be triggered or accelerated by inflammation related to mast cell activation syndrome, though we do need more research on this. CCI leads to increased mobility or instability that can precipitate deformation of the brainstem or the upper spinal cord, including the ventral brainstem compression and basilar invagination. And this increased mobility and instability can also create a traction force on the blood flow into the brain via the vertebral artery or alter venous or CSF outflow from the skull itself. There's a whole host of extensive symptoms that we call the cervical medullary syndrome associated with craniocervical instability. But I think the most important thing to remember here is that CCI or atlantoaxial instability appears to mediate or drive symptoms of dysautonomia, including orthostatic intolerance or gastrointestinal dysmotility or sympathetic overdrive. And when I have a patient that is resistant to pharmacotherapies for these things, no matter what I do, drugs that often work for many patients are not working for that patient, we sometimes have to look upstream and say, is there a neuroanatomical reason that these drugs aren't working that is preventing us from seeing progress here? There's also a complication that often comes with cervical instability, but not always. It can be found independently as well, called acquired or occult tethered cord syndrome. This is an anatomical restriction of the normal movement of the spinal cord via the filum terminale, tightening or tethering. A healthy filum is a fibrous, collagenous, and elastic band connecting the conus medullaris or base of the spinal cord to the dural sac. In tethered cord, this filum appears to be morphologically altered with fatty tissue, dysplastic axons, fat and vascular lacunes, and even congested veins. So when they actually
I'm so
look at
sorry,
this,
Brayden. You have a 3-minute warning.
when they look at this area under electron microscopy, we see all kinds of abnormal architecture. And in fact, when they stain that histologically, you see significant inflammation from white blood cells, microglial cells, and mast cells. The pathology from acquired or occult tethered cord appears to be from forcible flexion, stretching the spinal cord against the filum, causing tissue damage and repair, inflammation, and altered gene expression, leading to a classic triad of neurogenic bladder or bladder use issues, lower extremity weakness or sensory loss, often worse on one side compared to the other, and lower back pain without other explanation. You can have all these types of symptoms here, but I think it's important to point out in this case that anchoring of the entire spinal cord via the presence of tethered cord may actually pull the brainstem into an anatomically disadvantageous position in which that brainstem is compressed or irritated by the surrounding soft tissue or bony structures. So in other words, tethered cord may drive or pull the brainstem into a position that leads to symptoms of CCI. So surgical detethering is a viable option for patients with tethered cord, and that detethering sometimes will reduce symptoms of craniocervical instability by reducing that anchoring of the brainstem into that disadvantageous position. However, it's possible that in fact the detethering could actually expose or exacerbate existing CCI as well. So the shift that you have in the brainstem from untethering may actually worsen the position of the brainstem in some cases. And very quickly, I wanted to touch on venous congestion or outflow obstruction syndromes as well that lead to what we call idiopathic intracranial hypertension or pressure. So we're recognizing this in more ME/CFS patients. 20% of ME/CFS patients have elevated pressure in their cerebrospinal fluid upon a lumbar puncture, but 85% of ME/CFS patients who do not have elevated CSF pressures on lumbar puncture still note symptomatic improvements from lumbar puncture, including things like diminished headache, improved fatigue, less brain fog, reduced tinnitus or ringing in the ears after that lumbar puncture and removal of CSF. Some of those having benefits lasting for weeks or months. So we think that the threshold for diagnosis is perhaps needs to be readjusted in patients with connective tissue disease and ME/CFS based on our kind of traditional definition for this illness. Venous compression and outflow tract obstruction can lead to this transient and often positional increases in intracerebral pressure, and sometimes even lead to spontaneous CSF leaks with associated headache, ringing in the ears, vision changes, and brain fog. Obstructions can arise from abnormal venous pathology with stenosis or narrowing of the veins or tortuosity, as well as from anatomical impingements, including something called Eagle syndrome, where this bony process called the styloid impinges on the veins. Disc herniations, and even other venous congestion syndromes may lead to congestion in the skull itself of venous flow. And I just want to point out here, this is a view of something called the infratemporal fossa, where that jugular vein leaves the skull. There are a lot of nerves in this area, including cranial nerves, and what's called the nodose ganglion, which is a ganglia of sensory neurons of the vagus nerve that are responsible for regulating breathing, blood pressure, heart rate, digestion, and even sensing of chemical and mechanical stimuli. And so when we have a venous congestion syndrome or an anatomical impingement in this area, it not only causes intracranial hypertension symptoms, but often nerve-based symptoms as well. And so there are surgeons now who go in and decompress this area to relieve these symptoms. And this is my last slide, just to point out that I think that we need to remember that clinical pathology in patients with ME/CFS, with HCDS, et cetera, very much depends on one's positioning in space, whether you're upright or whether you're laying down, whether your neck is rotated, flexed, extended, or whether even if you're at altitude or if the barometric pressure is changing. This can alter the way these type of pathologies present, particularly things like intracranial hypertension or even GI dysmotility. One of the problems with the testing for that is that it's often done when people are laying down, and they may have symptoms when they're standing up, but not when they're laying down. So with that, I appreciate your attention, and I want to thank you.